Thank you for that introduction. I am Dr. Andrea Mucci, and I am the medical director of the Extraordinary Clinic at Cleveland Clinic Children's. And today it's my honor to be here to talk to you all about how Klinefelter and AXYS syndromes are at an increased risk for developing diabetes. So by the end of this short session, my hope is that you'll be able to identify groups of people who may be diagnosed with diabetes and specifically know that those with XY syndromes are at an increased risk for this, to understand the cause of different types of diabetes, and to understand the basics of how diabetes is diagnosed and treated. So who can get diabetes? The short answer is anyone. So any sex, any age, any ethnicity and race. And as we'll talk about later, different types may be more likely to develop in different individuals, including those with XY syndromes. We know that people with XY syndromes, including Klinefelter syndrome, are not all the same. So there are many people on this call that may have the exact same genetic diagnosis, but of course, the medical conditions and how the condition affects them is different. The medical way of saying this is that there's a lot of phenotypic variation. So what you see in different patients varies. And the same is true about diabetes. So there's a number of factors that can affect this, including age, genetic background, the degree of testosterone deficiency or hypogonadism, lifestyle, as well as timing of the diagnosis. So I already mentioned that the risk of diabetes is increased in Klinefelter syndrome and XY syndromes. This is because both metabolic syndrome, which I'll talk about later, as well as autoimmune are increased in these conditions. And these in turn increase the risk of diabetes. Low testosterone does play part of the reason why this happens, but it's not the only thing. So what are the different causes of diabetes? I think most of us have heard of type 2 diabetes, and some of you may have heard of type 1, also known as juvenile diabetes. I am not dyslexic. The numbers are written in the opposite order because type 2 diabetes is more common in the general population and in the XY syndromes than type 1, although both are at an increased risk. These are the types of diabetes this presentation will focus on. However, I did want to mention that there are other forms of diabetes, such as medication-induced diabetes, other types of genetic diabetes, and diabetes that can occur in 6 states. So one of the most important things I think everybody should know is what symptoms would a person with undiagnosed or poorly treated diabetes have? So you can see from the pictures here, that person may always be thirsty. They may complain of blurry vision. They may have slower wound healing. They may feel like they're always hungry or tired. Older people may experience sexual problems. They may have numbness or tingling in their hands or feet, and they may frequently need to urinate. As an endocrinologist, the two that I really emphasize for my patients and families is to monitor for thirst and urination. So if you're constantly running to the bathroom or constantly thirsty, it would be a good idea for you to have a discussion with one of your healthcare providers about whether or not you may have diabetes. So before we get into diabetes, I wanted to go over what the body should do. So in this diagram, the red line is the blood vessel, and these yellow balls are the glucose. And our blood glucose comes from our diet when we eat carbohydrates, and also the liver releases some of these stored molecules. So we have glucose in the bloodstream, and then normally our pancreas responds to this glucose by producing and releasing insulin. In this diagram, the insulin are the keys, and that is because insulin is the key to taking the glucose out of the bloodstream and allowing it to enter the cell for energy. So insulin allows the cell to uptake the glucose and use it for energy. And this is what should happen and does happen in most of our bodies. But where does the insulin come from? So we all have an organ called a pancreas. And within that pancreas, there are these little islets, which are collections of cells. And each of the different cell types make different hormones. Specifically in this islet, you see the many red cells that are colored red, and these are known as beta cells. And beta cells are what the body uses to respond to glucose or sugar and produce insulin. So the beta cells of the pancreas produce our body's insulin. So I know that can be complex, so I just wanted to summarize the same thing on one other slide to say that when our blood sugar goes up in our bloodstream, our pancreas reacts by producing insulin, and the insulin is what allows the cells to take the glucose from the blood and use it for energy, and this hence normalizes our blood glucose levels. So now that we have a better understanding of what should happen, let's talk about what happens in various forms of diabetes. So because type 2 is the most common, I was going to start with that one. And as I just mentioned, type 2 diabetes is the most common form of diabetes in the general population and also the most common cause of diabetes in Klinefelter syndrome and other XY syndromes. Type 2 diabetes has very strong genetic links, so it does tend to run in certain families, and specifically it is in a higher prevalence in certain ethnicities and races. It is tightly linked to something called metabolic syndrome, which is a constellation of medical conditions that can increase your risk for problems with your heart health later in life. These conditions include diabetes, as well as high blood pressure, cholesterol, and obesity. And one of the things that links many of these medical conditions together is something called insulin resistance, which I'll talk about on the following slides. So what happens in type 2 diabetes? The same as in regular, we're getting most of the glucose in our bloodstream from the carbohydrates that we eat, and also some from liver release. But then the insulin is resistant to doing work. So insulin resistance usually has insulin present and floating around. It just doesn't work. So we have the key, it just doesn't fit. It doesn't do what it's supposed to do. And because of that, glucose stays in the bloodstream and cells lack energy. So people with XY syndromes, including Klinefelter syndrome, are at an increased risk for type 2 diabetes. And the range of studies indicate that this can be as much as 10 to 40% of individuals with these conditions. The reason there's such a wide range is because these numbers come from different research studies using different populations from different parts of the world and of different ages. They do think that people with extra chromosomes in addition to the 47, such as 48XXXY, may have an even higher incidence of getting type 2 diabetes. We do think that hypogonadism or low testosterone is one of the big risk factors and reasons why we see this increased type 2 diabetes in people with XY syndromes. What we're not sure is exactly how the age of diagnosis and testosterone treatment affects the risk of developing diabetes. What we do know is that one of the strongest risk factors is how much weight you carry around the belly. So that's called central adiposity. So this body habitus and shape develops often even before puberty, again, bringing in the possible question about the link about testosterone levels. In the general population and in the XY syndrome population, we do know that there are a number of social and economic factors that also can increase our risk for type 2 diabetes. In addition to the general population's insulin resistance causing type 2 diabetes, we also are now learning that people with XY syndromes may have additional inflammatory factors that can contribute to this insulin resistance. So now that we've talked about type 2 diabetes, I did want to move on to talk about type 1 diabetes, which is also sometimes referred to as juvenile diabetes, because a lot of people with this condition are diagnosed when they're young. However, it can be diagnosed at any age. So what happens in type 1 diabetes? I'm going to go back to the same picture. And of course, our glucose is coming from the same place, so the carbohydrates we eat. But now our pancreas just isn't making insulin. And as I'm going to discuss on the next slide, this is because of an autoimmune reaction. And I'll explain what that means on the next slide. But because we're not making these keys, so in fact, the keys wouldn't be there at all, we're not able to uptake the glucose to our cells for energy. And then the glucose stays in the bloodstream and the cells lack energy. So type 1 diabetes, as I mentioned, is an autoimmune condition. And what autoimmune refers to is when our body's immune system, which is supposed to fight off things that aren't supposed to be there, like infections, gets confused and it attacks itself. In type 1 diabetes, it attacks the cells that make the insulin, so the beta cells. So this shows how the development of type 1 goes through a number of stages so that there's a starting point, like a genetic risk, which, as we're discussing, people with XY syndromes have an increased genetic risk. And then at some point, there's some form of immune activation. Sometimes this can be linked to an illness such as a virus. And in other cases, we're unable to specifically say what could have been the possible trigger. But eventually, our body makes an immune response. And so in this case, the part of the immune system we're talking about is something called antibodies. And these antibodies are against different proteins related to the beta cells. You can have antibodies and not have diabetes. So you can have normal glucoses in the first stage, but then over time, a certain number of these people with the antibodies will progress to getting abnormal blood sugars and eventually diabetes, or type 1 diabetes specifically. So what do we know about Klinefelter syndrome and XY syndromes and this type 1 diabetes? So there is about a 2 times increased risk of these individuals developing type 1 diabetes compared to 46 XY men. In one recent study, they looked at a group of individuals with Klinefelter syndrome, and 8% of them had some of these antibodies associated with type 1. And that's compared to about less than 1% in a 46 XY population. And so you may be saying, why is this important? Why is she spending so much time teaching us about type 2 versus type 1? And it's because a lot of people will just assume that diabetes is due to type 2 because it's the most common. But as we now know through this discussion, that type 1 and type 2 diabetes are actually different. So the causes of the high blood sugars are different. And this not only impacts the treatment, which we'll talk about on a later slide, but also, some of the more complex things like insurance coverage for medication and things like that. So it's important that if you or your loved one develops diabetes, and even if the doctor says it's type 2, it's important to ask, have we tested for type 1? Do we know if there are any antibodies? So this slide just shows how type 1 and type 2 diabetes can overlap. So they have, in the central part, they have many of the same symptoms, and both of them require a healthy lifestyle and medical supervision. And both can be complicated by other health problems, which I'm not going into today. However, type 1 is when the body does not create enough insulin, and that's because of the autoimmune destruction of the beta cells. And hence, type 1 diabetes requires insulin, whereas type 2 is related to insulin resistance, which is more closely linked to genetics, aging, inactivity, and obesity. So I don't think it's important for you to know the exact diagnosis of diabetes, but I just want you all to be aware that when you check a blood sugar, it's very different if you're fasting. So fasting means only water for 8 hours before, or not fasting. And that can be even, a little sneaky sip of coffee with milk and sugar in it. Even one sip of coffee before your blood work, if you forgot, is the difference between fasting and not fasting. And it's very important because that one sip of coffee could make you look like you have diabetes when you don't. So when you're asked to do fasting blood work, please make sure to only have water because it very much affects how we interpret the numbers of the blood sugars and whether or not you would have diabetes, prediabetes, or be normal. So in addition to the blood sugar, there's this other blood test called an A1C or a hemoglobin A1C. And what hemoglobin is it's a protein that's in our red blood cells, and it's designed to carry oxygen. But some of these proteins get sugars attached to them. And because the life of a red blood cell is 3 months, the amount of sugars attached to the hemoglobin is reflective of what your average blood sugar is over those preceding 3 months. So in this little figure on the right, you can see that normal is below 5.7, so 5.6 or below, and diabetes is 6.5 or higher. And in between there, it is called prediabetes. Hemoglobin A1C is also used to monitor how well we're controlling diabetes after we find out we have the diagnosis. So again, at diagnosis, an A1C over 6.5 is consistent with diabetes. And then once we know we have diabetes, whether it's type 1 or type 2, our goal is to get our A1C less than 7%. And the reason we want to do that is what minimizes some of the complications of diabetes, specifically those of the small blood vessels. Another measure of diabetes control is that we want our blood sugar within range 70% of the time. This is difficult to say when you're just doing finger pokes, but now with the new technology of continuous glucose meters, time in range is one of the outputs. So if you have diabetes and you use a continuous glucose monitor to monitor your blood sugars, then your endocrinologist will be able to review this data with you at your visits. So the treatment of the diabetes depends on the cause. So on the left here, we have our type 2 diabetes, which is related to that obesity and metabolic syndrome or insulin resistance. And because the body is still making insulin, you can sometimes use medications that help the insulin to work better. So this is where we use medications like metformin or some of the newer medications on the market like GLP-1 receptor agonists. So these are the Wegovy, the Ozempic, and then other ones like Mounjaro that affect other hormone levels indeed. But some people with even type 2, if you've let it go too far, your pancreas just gives up on making insulin, and or if it's severe enough, you still need to use insulin. So just needing to use insulin doesn't tell you if it's type 1 or type 2. But if someone is able to use just metformin, then that tells you that it's likely type 2, because in type 1, metformin's not going to work because you're not making insulin. So the only way to treat the autoimmune form of diabetes called type 1 is unfortunately to take insulin. And the two main ways that we can do this is either with daily injections or with these new devices called insulin pumps. And I should say they're not new. What's new is that the insulin pumps can talk to the continuous glucose monitors to adjust the insulin, which is called closed loop diabetes management. So just to revisit our learning objectives, I hope that now that our session is almost over, that you know the groups of people who may be diagnosed with diabetes and understand that people with XY syndromes are at an increased risk, that you understand a little bit about the causes of the different types of diabetes, and you understand the very basics of how diabetes is diagnosed and treated. In summary, diabetes mellitus is more common in individuals with Klinefelter syndrome and other XY syndromes. That type 2 diabetes is more common than type 1. However, type 2 is still at an increased risk compared to the general population. That it is important to focus on healthy lifestyle from a young age and across the whole lifespan. as this can impact the progression of diabetes and its management. At home, it's important for all of us, whether we have an XY syndrome or not, to monitor for symptoms such as drinking or peeing too much. And if we're concerned about these things, to talk to our doctor. That once the diagnosis of diabetes is made, I think it is worthwhile meeting with an endocrinologist because they can make sure that they've evaluated to make sure it isn't type 1 and or clarify the cause of the diabetes and be the most aware of all the different possible approaches to management. So that's all that I had to share today. If you all can just reflect in your minds and think about one thing you learned from this presentation, that can help to consolidate that learning. And if there are things you're still confused about or other things you want to learn about that have not been addressed in the chat yet, this would be a great time to ask those questions. Thank you.